all met Andrew, but Andrew's now our division head through UBC for cardiology, and so he's in charge of this CASPER registry. So CASPER is a systematic assessment of patients with unexplained cardiac arrest. So this person would be enrolled in CASPER. That's where all these tests have been done, and there's no identifiable cause after the initial echo, angiogram, and baseline ECGs. So far, up until 2009, they've enrolled 63 patients. It's close to double that now. And the treatment or the investigation algorithm is this. And this is sort of what we do, just sort of put into an algorithm form. So if somebody has a cardiac arrest, they get an ECG, usually a resting ECG. I'll talk about the signal average ECG in a moment. They get an echo. They have the usual cooling and resuscitation, of course. And then they have a coronary angiogram. So this is sort of where we would stop most often for the routine investigations. After that, there may be other testing done. I'll come back to this. So I spoke earlier about this early repolarization. So this is previously deemed a normal variant. So and this is very subtle. A little bit of ST elevation in the inferior leads. It's normal, or it's more normal to see it in the precordial leads, but if you see it in the inferior leads, it's a bit funny. And if it's associated with this notching here, that's abnormal. The normal variant can affect 5% of normal people. So, and then the risk of cardiac arrest is 1 in 100,000, and then that'll increase to 11 in 100,000 if there's this notching here. So that's what I meant earlier by saying that the incremental risk is only a little bit, and the story is not quite there yet. Because if you had an ECG and you saw this, you should still sleep well at night, because 5% of the population has it, and your risk for cardiac arrest is quite low.
Is that in all leads, or?
No, it's predominantly the inferior leads.
Don't you have that same picture with cold patients?
Yeah.
That's confusing.
Yeah, it is, and you can have this in normal people. That's the. Oh, it's the J waves. Yeah, more J waves for sure in cool patients. Absolutely. This is what a signal average ECG looks like. So what it is if we try and look for really really small abnormalities. So what one might say is, well, why don't you just amplify up a normal ECG, and then you can see absolutely everything. But you would see a lot of artifact. So what they do for a signal average ECG is you take 200 QRS complexes, for example. Each QRS complex overlays the previous QRS complex. Artifact will happen randomly. So if it's not a reproducible problem, a reproducible finding on the ECG, or it occurs randomly, it won't add up onto the regular ECG, so that'll be discarded. So it signal averages. Should I say that one more time?
Sure. Yeah.
So if you want to, so what we want to see is if there's any scar within the heart. Scar delays the conduction through the heart, and so at the very end of the QRS complex, you might have, so that if you imagine what an ECG would look like, you'd have the QRS complex, it would come down and up again. Now there might be some little fibers that conduct at the very end. So if you took a regular ECG and just amplified it, you'd get the huge QRS, and you'd get a lot of stuff at the end, but you wouldn't be sure if it was just because the person was moving. So if you overlap a QRS complex 200 times
Onto itself?
onto itself,
Okay.
anything that's real will happen every time. Anything that's not real will be discarded. They'll say, oh, that only happened on one of the QRSs, I'm going to discard it. So that way you can get this stuff here, which is very low amplitude, but very abnormal signals. So normal QRSs, and I'll show you an example of that, it goes up and down, and everything's turned positive, which sort of also makes it very confusing. But it goes up and then down and then stops. But if you imagine you've got a big scar in your ventricle, and you depolarize through the ventricle, and as you get to the scar, it tries to get through there, but there's all these little fibers that aren't conducting very quickly, and so that's all this. So it's continuing to conduct, but you don't see it on a baseline ECG.
So that's indicative of scar tissue.
Yeah.
Okay.
Yeah. So this is called a signal average ECG. We do have the option to do these. A couple of the carts downstairs have them. So yeah, if you ask Sean, he'll be able to do it. And loaded into views now too, which is good. Okay. So this is normal. So it goes up and then goes down all of a sudden and stops. This is another interesting case. So this is the real deal. This was published in that same article that Andrew published in Circulation. So normal rhythm, normal ST segments for the most part, and then here ST segment elevation starts to get some irritability with some PVCs, and then has polymorphic VT, recurrent runs of polymorphic VT, and then it stops. So this was a person who actually had spasm. So and they managed to capture this on the telemetry, which is very interesting. I laugh and give Andrew a hard time because it says up here alarm silence. So that's so after resting ECG and then signal average ECG, so we'll go on to imaging, and so spasm's one of the things we'll look for on imaging. So this is an old slide, but you can see where they give ergonovine, and then you go from a little bit spasmed to very spasmed, and then you give nitro and it improves. So that's what we're looking at with that. And with a bit of arm twisting, they'll do that for us. After all these imaging tests, so depending on the echo, we might go to cardiac MRI, and if they're getting a defibrillator, I usually will do that before they get their defibrillator, because after they got the defibrillator, we can't get an MRI. And in the future, when we have defibrillators that can go through the MRI scanners, we'll probably still do it before, because there will be so much artifact from the leads that we'll want to really get good images. So we'll go on to exercise stress testing. So you might say, why are you doing that when you've already got an angiogram? But surely that's the gold standard. Well, here's one of the cases that we published in JCE. So this is a woman who has baseline, so family history of cardiac arrest. Baseline QT interval looks pretty normal, right? Nice QT. The QT morphology is a bit funny. So she's got these T-wave inversions, and she was well. So a bit funny. And then she exercises, and the QT, the T-wave goes out to here. Just crazy. So usually the T-wave should end halfway, before halfway between the RR intervals. But her T-wave almost ends at the RR interval. Not only that, but the T-wave flips with every beat. So that's called T-wave alternans, and that's very abnormal and dangerous. So the point from this is that is that we look at the QT interval as well when we there's an example when somebody has an exercise stress test, because inherited long QT syndrome is a cause of cardiac arrest. Now that occurs in 1 in 2,500 people, and accounts for between 7 and 23% of all unexplained cardiac arrest. And importantly, it's familial. So if you identify somebody who's got it, you can protect their family members with beta blockers. Beta blockers are 99% protective in long QT syndrome. Another thing that we look for in exercise stress testing is this thing called CPVT, or catecholinergic polymorphic VT. This is typically when people exercise, they'll get what's called bidirectional VT. So this is a QRS, 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 and it's flipping its axis. But it's not like polymorphic VT where it is twisting with points. This is every other beat flips its axis. And this is also an inherited arrhythmia. It's quite rare, so 1 in 10,000 people get it. And it's due to specific genetic abnormalities and usually calcium handling. So we can identify that in exercise stress testing as well. Sometimes we'll do adrenaline infusions, and that's usually to identify the same problems as in the stress test. So in people who have long QT syndrome, so this is the same sort of case as I showed with the exercise stress testing. So this is baseline, pretty normal QT interval, and then the QT gets very abnormal with epinephrine. This is not that important, but it just shows that it is abnormal in long QT syndrome. We've done some procainamide infusions, so these are now no longer being done in the CCU, but are being done in the cardiac short-stay unit. So if somebody has a cardiac arrest, usually the approach, as I'm sure you've seen, is they have their MRI, echoangiogram, echoangiogram, baseline ECG history, assuming they're an idiopathic VF arrest, then they get a defibrillator, then they're discharged. And then we bring them back and we do this testing to see if we can identify, they're protected now, and we can see if we can identify a familial cause so that we can treat their family members. So the thing we're looking for in the procainamide infusion is to see if we can bring out Brugada syndrome. So this is a patient with, we usually look for this, well, for this pattern, but this is a case of somebody who's pretty normal baseline ECGs, and then we give them procainamide, and it becomes very abnormal, and this typical pattern of Brugada syndrome, where you get sort of RSR and V1, and then a biphasic ST elevation, and then it's biphasic T wave. So our T wave inversion. So this is pretty typical of Brugada syndrome. There are different ways to bring it out, probably more than you want to know, but sometimes we'll do high leads. So instead of having the traditional V1 and V2, we put the leads up 1 intercostal space and then 2 intercostal spaces, and see if we can show this pattern in those positions. So Brugada syndrome accounts for 9% of all unexplained cardiac arrests. It's autosomal dominant, and it's usually a sodium channel problem. So this is another inherited arrhythmia where echo's normal, baseline ECG can be normal, cath's normal, and they have a cardiac arrest. Any questions about that? I feel like I'm going through very, very too quickly.
I'm just wondering if I can sign up for an EPS study, please.
Yeah, no, you haven't.
Soon.
So if somebody has, if you've got, your family member has Brugada and they're doing testing on you, and are they doing it through giving you, is it through just a blood test, or are they doing these procainamide infusion things?
Yeah, so it depends. So usually what happens is there are different, so the people you'll see are come in with cardiac arrest.
Mm-hmm.
Then we put the ICD in. I see them in the office or see them in cardiac short stay for the procainamide infusion. If then they have this type 1 pattern, which is that pattern I showed you, then they'll be labeled